Welcome to ATCM, the Emergency Medicine channel. Today I will be presenting a burns case to you. Can we start, sir?
Please.
An 18-year-old male patient was brought to our ER with a history of burns. On initial 10-second assessment, patient was conscious, oriented and obeying commands. His airway appeared patent. There was no soot particles in the airway. There was no upper airway edema or lip edema. There was no deep burns in the face. There was some burns in the face. But
Mama, can you tell what is the type of burns so that we will have an idea before?
This person was having both first degree and second degree partial thickness burns.
More of like a mechanism kind of thing, so that
this person actually was trying to rescue two cats from the burning fire.
Okay.
So that time flame. So
okay.
His both upper limbs and the face got exposed to the fire. Breathing part, his respiratory rate was 18 per minute, saturation was 99% in room air, chest exertions were normal, there was no chest burns.
Before presentation, how long before this event happened? Immediately or?
2 hours back.
2 hours before, okay.
There was no chest burns, bilateral air entry was equal and there was no wheeze. Circulation, his heart rate was 96 per minute, his blood pressure was 110/80 with a map of 90, CRT was less than 3 seconds and all peripheral pulses were felt equally and bilaterally. Disability, his GCS was E4, V5, M6 with pupils 2.5 mm bilateral reaction. Exposure, his GRBS was 102 milligram per deciliter and hypothermia was prevented by blanket. I asked his pain score was 5/10, so I offered him analgesics, paracetamol, 1 gram IV was given.
Just looking at the BP, can there be any issues in just measuring the BP in burns patient?
Yes, sir. There can be issues in tying cuff and all. If that area is burned, there will be issue in tying cuffs. And
then what will be the alternatives?
Lower limb BP can be taken. Then arterial BP. This patient arterial BP cannot be taken, or else arterial BP or CRT can be used. CRT.
Okay.
A baseline blood gas analysis was taken, sir. Initial pH was 7.42, PCO2 was 35, bicarbonate was 22, the lactate of 1 and potassium was 4. His percentage of burns was assessed. He had facial burns with burns over the palm and the dorsal aspect of the hand on both upper limbs, and in the right upper limb he had burns over the forearm also, anterior aspect of the forearm. So total, according to the Lund-Broder chart, it will come as 11% burns.
Can you just elaborate on how you calculate? How the distribution of percentages?
We will be using rule of 9 in adults and children can be used, or we can use Lund-Broder chart, or we can use palm rule. So according to 9%, if you are using the 9%, which is the simplest rule, so in that in adult and children it is different. So out of the 100%, 1% will be for perineum, and the rest of the 99%, that is 9, that we will take as 9 into 11. So 11 areas of the body will carry a score of 9 each. So the head and neck will carry a score of 9. Then left upper limb will have a score of 9. Right upper limb will have a score of 9. Anterior aspect of the left lower limb will have a score of 9. Posterior aspect of the left lower limb will have 9. Similarly, right side also, anterior and posterior 9 and 9 each. And anterior part of the chest will be having a score of 9. Posterior part of the chest will be having a score of 9. Anterior abdomen will be having a score of 9, and posterior part of the abdomen will be having 9. So total 9 11s and 1% for the perineum. In case of children, the rule of 9, 18%, children's head and neck is taken totally as 18%, and both the lower limbs together is taken as 27%. Then the left upper limb will have a score of 9, right upper limb will have 9, then anterior and posterior part of the chest and abdomen will be having 9 each, so 9 into 4. So totaling and perineum 1%, totaling 100%. Then we can use the palm method. Palm method, when we are only using the palm, When we are using this palm rule, we should take the patient's palm as the percentage. So if only the palm area of the patient is coming, then that is half percentage. If the palm and the fingers are coming, that is 1%. So with that patient's palm and hand, we can calculate the percentage. Then it's a Lundbroda chart, sir. Lundbroda chart, according to age, it will vary. Each percentage will vary, sir.
Okay.
Then in this patient, percentage of burns was 11%. So initial analgesic was given. Then 2 large bore IV cannulas were inserted and ringer lactate was started. So according to Parkland formula, his correction should be 3 liters should be corrected over 24 hours. So first 8 hours we should correct 1.5 liters. So RL was started. Then his limb was both upper limbs were elevated, and we have given a thorough wash. When we are giving a wash, we should wash the limb with running water. With either we can first we should clean all the debris. That means any ruptured blisters are there or any necrotic patches are there, that should be cleaned off, and running water should be used. We should avoid any direct application of ice water to that, and we should avoid povidone iodine or betadine to the wound, because it can increase the depth of the wound. And then after that, wound dressing was done. So
what's the minimum time recommended for this running water?
20 to 30 minutes. We shouldn't wash more than 30 minutes because it can cause hypothermia.
And you told something about blisters.
Blisters also, if there are ruptured blisters, we can remove the upper part of the blister. If there are patent blisters, if they are there, we are not supposed to rupture the blisters because that can cause infection. But only we will be rupturing the blisters if the size is more than 6 centimeter, and if it is over
centimeter or
6 millimeter, and if it is over a major joint.
You want to add anything?
That was done, sir, and limb was kept elevated to avoid edema. Ample history, there is no allergies, no past medical history. Last meal was taken 3 hours back. Events, patient had a direct exposure with the fire while attempting to rescue his kitten from the fire, and he burned his face and both upper limbs. After the event, this happened 2 hours back. After the event, there was no history of any breathing difficulty or any other airway difficulties were not there, sir. System examination, there was no pallor rectus, clubbing cyanosis, lymphadenopathy or edema.
Just I will wait there. What are the airway issues you are anticipating in a burns?
In airway and breathing, what are the problems that you can expect? Because this patient is having facial burns.
In the airway, in the upper airway, what we should expect is there can be carbonaceous material or soot materials in the upper airway, or because of third space loss, there can be facial upper airway edema, lip edema and tongue edema, and upper airway pharynx and laryngeal edemas can be there. And the nose, nasal area, there can be stinged hairs can be there. Then vocal cord edema can be there. Then because of the exposure with the soot particles, there can be bronchospasm will be there. And if it is a chemical exposure, chemical alveolitis can be there. These things are we should expect in the airway and breathing. And if there is burns to the neck, circumferential burns can also impair the breathing.
That's regarding the mechanical thing. Anything with relation to inhalational issues?
Inhalational issues, we should anticipate carbon monoxide poisoning, and also cyanide poisoning should also be considered. More of carbon monoxide poisoning. In that case, we should give 100% O2 oxygen should be given to the patient, or hyperbaric oxygen specific treatment.
One more thing you need to remember is that at the immediate time of presentation, things may not be that bad. In due course, while the patient is in ER, the patient can develop critical obstruction at some point because of the evolving edema. Okay.
What are the problems in circulation that you expect in such a patient?
Circulation, we should expect a hypotension. Hypotension can be because of two causes, because of the evaporation and loss of fluids, or it can be because of the vasodilatory action and third space loss can also be there. So patient will be dehydrated, and in case of burns, extensive burns and all, there can be coagulopathies.
Okay, in such case, if you are not able to cannulate, is there any other alternate option that you can do?
Venous cut down should be planned, sir. Late complications, there can be rhabdomyolysis and acute kidney injury should be.
Okay. In disability part, if the patient is coming with face burns and he is having low sensorium, is there anything else you will expect? Or in normal burns patient is having low sensorium?
Carbon monoxide poisoning should be anticipated. Then it can be because of any alcohol intoxication or associated trauma causing low GCs. Trauma and head injuries causing low GCs.
Okay, proceed.
Head to toe examination. In the face, there was superficial burns over the forehead and the lateral aspect of the face, and there was superficial partial thickness burns over the chin and cheek. Eyes and nose were examined. There was no stinged hairs, and oral cavity examination was normal. Neck examination, there was only superficial burns. There was no, that means only first degree burns.
Yes, you are telling, can you elaborate about degree of burns?
First degree burns means only involving the skin area. So there will be only redness will be there, and patient will be complaining of pain. Second degree, there is partial thickness burns, superficial partial thickness burns and deep partial thickness burns. Superficial partial thickness burns involves the dermis part up to the papillary dermis, and the deep partial thickness burns involves the reticular dermis also. So in the superficial partial thickness burns, patient will be having pain, redness will be there, and color changes will be there. And in the third deep partial thickness burns, patient will be having only pain to pressures, and variable colors can be there. Then in the third degree burns, it will involve the subcutaneous tissue also, so it can be waxy or leathery grey or dry, and fourth degree burns involve the muscles and bones. Healing time also, superficial burns, that first degree burns will heal within 7 days, superficial partial thickness burns will heal in 7 to 21 days, and more than 21 days for deep partial thickness burns, and there can be scarring.
Okay. Blister formation will be there in which degree of burns?
Blister formation, superficial partial thickness and deep can be there.
Okay, is there any difference between blister of superficial partial thickness and superficial deep thickness?
It will be more tense in superficial partial thickness burns, and it will be tense.
It will be less tense in superficial partial thickness and more tense in deep partial thickness. And superficial partial thickness burns blister will rupture easily, and this skin will settle on body, whereas it won't happen in deep partial thickness.
Then the limb examination, in the upper limbs, right upper limb, anterior, in the hand anterior and posterior part of the there was second degree partial superficial partial thickness burns in the both upper limbs, and superficial partial thickness burns in the right anterior aspect of the forearm. Then moving on to the respiratory system examination, upper airway examination, there was no soot, edema, hoarseness of voice, or any stinged hair. And lower airway examination, there was no added sounds or no features of bronchospasm was there. Other system was normal, sir. So in this patient, we directly, so this is a 11% burns in a 18-year-old male patient. So management wise, airway, breathing, circulation. In airway wise, at present the airway is patent. Breathing also, there is no airway compromised, or there is nothing restricting the breathing as of now. Then circulation.
This patient is having burns in hand. So where will you measure saturation?
Saturation in the lower limb, saturation can be.
Lower limb, any other places where you can measure?
Ear.
Earlobe. Okay. This patient is having burns. Okay. In exposure part, did we remove all those rings and some encircling things, like bracelets and what should be?
This person was not having anything like that, but ideally we are supposed to remove that, because these things can cause a tourniquet effect. If the swelling increase, that can itself act as a tourniquet. This person, 2 large bore IV cannula was inserted and fluid ringer lactate was started. Then adequate pain control was given and dressing was done, sir.
What was the choice of analgesic?
Paracetamol was the choice of analgesic. Otherwise, we will go for opioids, minor opioids and strong opioids can be. NSAID should be prevented because that itself can cause renal failure, and in cases like electrical burns there can be rhabdomyolysis and renal failure. And this person, we didn't insert a Foley's catheter, but urine output was measured. We should expect, we want a urine output of 0.5 ml per kg per hour urine output should be there. And dressing was done with silver sulfasalide dressing was done, sir. So this dressing should be first initial antibiotic dressing should be done. After that dry gauze should be applied and dry gauze roll dressing should be done. And if at all, and this dressing should be done twice a day. If at all we are going for a synthetic occlusive dressing, we can keep a synthetic dressing on the wound, and we can, when the wound heals, the synthetic dressing itself will come out by its own. So we don't have to dress twice a day.
Did we give TT prophylaxis for our patient?
Yes, sir. That also should be given.
Regarding TT, can you tell something more about it? Because like, what history are you going to ask the patient? Like,
there was, if at all the patient has taken a TT injection recently, then we can.
What's the time frame?
3 months.
5 years.
5 years.
Theoretically 5 years.
Regarding antibiotics, what will you start for such a patient?
Systemic antibiotics usually is preferred only in case of 4th degree burns, sir. Otherwise we can give only topical antibiotics are required. So silver sulfasalide can be given, sir. It is usually avoided in case of sulfa allergies or in case of pregnancy or in lactating woman or G6PD deficiency. Otherwise we can give dressing, Bactrim dressing with neomycin. It can be given, or some dressings like mifenade is there. Mifenade, one advantage is that mifenade can penetrate through the eschar and will heal the wound, but disadvantage is that it can cause metabolic acidosis. So usually it is not preferred.
What are the indications for admission in a burns patient?
Indications for admission is if at all the some other type of burns like chemical burns, inhalational burns requires admission. Then in a person with multiple comorbidities requires admission. Then if there are some logistic issues or some emotional factors, or in case of children when we are suspecting battered baby syndrome and all, they requires admission. Then if the degree of burns is more than 20% in a age group between 10 to 50 years, and if it is more than 10% in less than 10 years and more than 50 years of age, and if any burns involving the face or involving the neck area, circumferential neck burns and all, and if the burns are involving upper limbs, upper limb means in the palms, the sole of the feet or perineum, they require admission.
Burns involving genitalia also?
Genitalia, perineal region. Electrocution, radiation.
You want to talk about the different kinds of burns in general?
There can be thermal burns, sir. There can be inhalational burns, radiational burns, chemical burns, and burns because of the flame or soot, sir.
Okay, what are the complications that you expect in such a patient?
Complications, there can be local complication and systemic complication. Local complications like local wound infection, compartment syndrome, etc. And systemic complications like coagulopathy, acute renal failure can be there. Hypotension, that is the immediate complication, can be there. Then rhabdomyolysis.
Okay. If such a patient develops rhabdomyolysis, what will be your treatment? What will be the change in treatment that you?
Fluid aggressive fluid management should be started.
What will be your target output in such a case?
0.5
in rhabdomyolysis?
1 ml per kg.
2 ml per kg.
What are things you're going to monitor if the patient is going to develop rhabdomyolysis? What are the indicators? How will you know, basically?
The potassium and the creatine kinase should be monitored. Then there will be acidosis, metabolic acidosis.
Anything in urine?
Urine myoglobin will be there.
CK value of more than 5 times the baseline value is an indicator for rhabdomyolysis and potassium myoglobin in urine. Okay. If the patient develops compartment syndrome, how will you know that this patient is going in for compartment syndrome?
There will be pain out of proportion. Patient will be complaining of pain out of proportionate of the analgesics given, and there will be pain on passive movements itself. There will be pain, sir.
Okay.
And compartment pressures.
In such a case, what will be your treatment?
Fasciotomy should be.
Okay. How will you? Okay, you are planning for fasciotomy. Surgical team will plan for fasciotomy. What is the thing they will do? Will they release pain in? Will they release that one compartment or something else also they will do? Whenever they are planning for fasciotomy for compartment syndrome, the nearby compartment also
should be
have to release.
Cause of death.
Okay. What will be the causes of death in such a patient?
Immediate cause of death are immediate cause of death can be because of asphyxia. Then other causes because of hypotension, fluid loss, or airway compromise is inhalation. Late complication can be because of sepsis.
Other than this burn site as a source of infection, what are all the source of infection can be there for this patient?
Gram-positive infection.
The sources. Aspiration is one area.
Then contamination of the wound can cause gram-negative infections can be there.
Yeah. So IV cannulus and Foley's catheter. These are the other sources of infection where you have to screen in such a patient. Not always because of that contaminated wound patient will have. This also can contribute for sepsis.
Okay, thanks.